We have with us the two editors of the PCSK9 forum, Professor John Chapman and Professor Henry Ginsberg. Gentlemen, this is a really interesting time because we heard yesterday that the first of this new group of drugs, the PCSK9 inhibitors, has been recommended for regulatory approval here in Europe. How important is this new development?
Simply tremendously important, Mike. We live in very exciting times. We've known for some years that the available agents to reduce LDL in individuals, particularly with genetically driven hypercholesterolemia, needed additional LDL lowering to really significantly reduce their cardiovascular risk, above all heart attack and stroke. And in fact, these agents provide us with the opportunity to, for the very first time, to lower LDL's levels to those that have been recommended by the European Society of Cardiology and the European Atherosclerosis Society. So these are tremendously important developments.
Dr. Ginsberg, what will this mean for your patients?
Well, Mike, for my patients, and I have a very tertiary kind of referral practice, I have many patients with familial hypercholesterolemia, the genetic-driven hypercholesterolemia. And on 3 to 4 drugs, most of them have LDL cholesterol levels well above 100, 120, 2.5 to 3 millimole. Many of them have already had cardiovascular events. And irrespective of the latest guidelines in the United States, most of us believe levels of LDL of 120, 3 millimole are not adequate for such patients. And we had run out of drugs. And now, not only can we probably take them off one of those 4 agents, but we can lower their LDL to 60 to 1.5 millimole. In addition, in the United States, the average LDL for untreated adults is about 130 to 140 milligrams per deciliter. So half of the people in the US who need LDL lowering can get an LDL down in the 60 to 70 milligram per deciliter range on the available drugs. But half won't, and a third certainly won't get much under 100 or 2.5 millimole. And we know now from the IMPROVE-IT trial that much lower than that is much better.
So what will this mean for the field of cardiology?
Well, one of the strong tendencies, Mike, will be to diagnose patients, particularly with genetic forms of hypercholesterolemia, much earlier, to treat much earlier. And under those circumstances, we anticipate that the disease process in the arterial wall, atherosclerosis as we know it, will be substantially delayed, which should result, and we predict, in a substantial reduction in heart attack and stroke.
I agree. I do think it will take several years to a decade to have complete acceptance of powerful drugs like this. They're injectables. The cost will certainly be an issue that cannot be ignored. And hopefully, as the number of individuals who use these agents increases, the cost would come down. But putting that aside, over the next 5 to 10 years, we'd expect certainly familial hypercholesterolemic patients to be in a position to never get vascular disease if they're started early enough. We still have the issue of identifying those patients and the question of primary prevention versus secondary prevention. There was always pushback against very aggressive primary prevention. But I think with safety and with cost taken into consideration, there'll be a balance, and we'll see how much benefit there is, and hopefully the benefit will spread.
Brown and Goldstein, the fathers of dyslipidemia, predicted that the end of the last century would see the end of heart attacks. Does this bring us closer to that goal?
Well, I think they will. I think there are many reasons people have heart attacks, but the underlying reason is atherosclerosis. Once you have atherosclerosis, why you have a heart attack, why a plaque ruptures for the most part. We know now it's not a process in most people where the atherosclerosis simply narrows and narrows and narrows the vessel until it's closed. We know that things happen in jumps and starts because of fractures of the plaque, a blood clot forms, sometimes large enough to cause a heart attack, sometimes large enough just to cause some chest pain. If you don't have atherosclerosis, that won't happen. But at the same time, even people with LDLs of 60 and in the 50s have heart attacks during those 5-year trials. So there is more to learn. There's hypertension, there's smoking, there's diabetes, there's endothelial damage from those processes. But it does seem clear, the lower the LDL will be, the less atherol you'll have, and therefore the less events you'll have later on.
Professor Chapman, how excited are you about these new drugs?
Well, one can't underestimate the significance of this event. One of the reasons that this is so exciting for me is because it coincides with some very new information provided by the latest DNA sequencing technologies, which within the last 2 to 3 years have shown us that the frequency of the genetic form of hypercholesterolemia, which Henry referred to, familial hypercholesterolemia, is at least twice as frequent in the general population as we had thought some 30 or even more years ago. So in fact, the true frequency is of the order of 1 in 200 to 1 in 250, which totally changes this perspective. So we now have a new challenge, and that is, can we reliably detect and diagnose, exactly as Henry indicated, these people, particularly in a family context, who are at this very elevated risk. But of course, as atherosclerosis is a silent disease for much of its course, this of course means that the family history is critically important, particularly for general practitioners and family doctors, to be able to identify families, particularly children, at risk, because these agents now provide us, for the very first time, with the possibility, as Henry indicated, of potentially eradicating cardiovascular events, MI and so forth, in the future, if we diagnose early enough and if we treat early enough.
I would add to that, though, the important point, the monoclonal antibodies that inhibit PCSK9 activity or any other inhibitors of PCSK9 activity are not going to replace statins. And now with the IMPROVE trial, they're not going to replace a combination of statin and ezetimibe, except in people who cannot tolerate statins. So because 50% lowering on top of a statin is miraculous, but 50% lowering without a statin is no better than the most potent statin. So we are talking about stepwise treatment. And these would be then, except for those intolerant patients, the third agents. But they're third agents that are more potent than each of the others, or at least as potent as the combination of the other two. And that's where, if you just do the arithmetic, we're talking about getting on the overall 75 to 80% reductions in LDL cholesterol in people. So that's amazing.
So what's your hope for the future?
Well, I think initially and if soon after this, the other pharma companies that have these drugs along the way also get approval, we will begin to see their use, I think, in the patients with familial hypercholesterolemia. And then in about 2 years, I believe, that there'll be 2 large outcome trials that will show us not only that they actually reduce cardiovascular disease, but that they are safe in, between the two trials, probably 30,000 or more people over a 5-year period. And they'll be followed by other trials of that order of magnitude. So the safety will be there. There is a concern that we're going to have many people who have LDL levels down in the range of 0.1 millimole, 0.25 millimole more likely, about 10 milligrams per deciliter, or 20 milligrams per deciliter, 0.5 millimole. And there's concern. I think the evidence overall says that will be safe, but until we have thousands of people followed for a period of time, we won't know for sure. But beyond that, we know that LDL cholesterol levels of 40 or 50, just about 1 millimole, not only are safe, but are beneficial in populations where there's very little fat and cholesterol eaten. The natural experiments say that those numbers are safe.
So finally, Professor Chapman, what's your take-home message?
Yes, probably a critical message that has been to some degree hidden from many clinicians, and which we've really only started to discuss in detail within the last 2 years or so, is the fact that one can never predict the response of any individual to any dose of any of our available lipid-lowering agents. And the reason for that is that genetic variation from individual to individual, we call it pharmacogenetic variation, results in that variability, particularly to statins. So for example, between the three of us here, if we each take the same dose of the same statin today, and we come back in a month's time, it may be that you'll be fortunate to have a 50% reduction. I might have maybe only a 5% reduction, and perhaps Henry 30. So that's an example of the impact of variation in genetic factors that produce proteins, particularly to pick up statins as they circulate, place them in the liver cell where cholesterol synthesis is inhibited. So this aspect means that for the future, the follow-up of patients over time will be absolutely critical to ensure that these agents are being used efficaciously, whether they're used in monotherapy or whether they're used in combination.
Professor Chapman, Professor Ginsberg, thank you both.
Thank you.
Thank you.